Good afternoon, everybody. We'll wait one more minute for our regulars to check in and log in. Happy first day of October. I don't know if it's a good thing or bad thing we're in October.
It's good that we made it this far.
That is very true. That is true. Not sure, Victoria. I'm assuming Victoria's coming from another meeting, so we'll go ahead and get started. Welcome everybody to our first HiPAM community meeting for this October 2020. It's good to see everybody again. We will, I think everybody here knows everybody. So if we have time before we get into the meat and potatoes of our discussion, we'll do our icebreaker, but I wanted to at least get past or not get past, but kind of run through the data piece so that we have a really good topic today led by some of our members to talk about vaccines and some of the impacts and differentiate between the different types of leading vaccines. So I'll wait for Victoria to log on, see if she has any comments, and then we'll get started. Hey, Victoria, how are you?
Hey, Thomas. Hi, everybody. Sorry, a little bit late.
No problem.
I think Thomas, you're leading today's.
Yep.
So,
yep. So last week, the icebreaker I asked everybody to think about was what food item or restaurant you were thinking about. I will say, as we go through the data, but something fun to think about is Halloween's coming up. What would you dress up as? Once again, assuming we don't have to worry about COVID, but what would you dress up as? So with that, I'll let that question permeate, but we'll go through. Oh, can I get access to share my screen, please? Perfect. Can everybody see the slides that are up, the HiPAM weekly COVID summary? Is it up? Okay, perfect. So second week of our new meeting flow. We're trying to spruce it up every single time. So please keep sending feedback to me and the rest of the team. We love to make this better for everybody who participates. So starting with a national snapshot, can I make sure? So last week when we looked at the trend, we were at 43,000 7-day case average. So we're slowly trending down from last week to this week. So once again, obviously week to week, there's a lot of nuances from a national perspective, but it's always good to have a sense of what's going on nationally. I know some of us are starting to look at shifts and trends from, there's any trend in the timing between what experiences on the mainland to Hawaii and even from Europe to the mainland to Hawaii. So it's always good to have a perspective from a national level. So focusing on Hawaii, so these are the numbers from last week provided from Hawaii Data Collaborative. So 106, 13.7, and 2.7. So happy to show that we are trending down for all of these metrics. Once again, there's a lot that goes on in between each week and changes day to day, but it's always nice to see a downtrending arrow for everything, especially the hospitalizations and the fatalities. In terms of our average for new cases from last week to this week, 96 cases was a 7-day average for last week, Thursday, 103 for today. So a slight trend up. Fatalities is trending down as well, but there's a lot more nuances than to just focus on one of these metrics. So that's why we provide a multitude of what we think are the most important metrics. For new hospitalizations, definitely the 70 average is trending down, which is good. It corresponds with what we're seeing with the decrease in new cases. ICU hospitalizations are also trending down in terms of current utilization. Also very good news. One thing to add is in terms of hospitalizations, I know I'm preaching to the choir. You guys are experts at this point. You study this a lot, but these are more of our lagging indicators. So while these are good, it only tells us what's happening in the hospitals today, but it reflects what happened in the epi curve, a couple weeks back. So we're trying to create and look at more leading indicators for better forward posturing changes. For our percent positivity, we increased 0.5% from 2.4 to 2.9. So that's something we need to keep an eye on as we move into flu season, and we're going to reopen in a couple weeks to trans-Pacific travel with our new testing strategy. And I believe the Lieutenant Governor had a press conference today. In terms of our testing turnaround time, this was very positive from last week to so this is going to be lagged a week because it takes time for DOH to compile the information. But from the 13th to the 20th, while the absolute numbers stay the same, majority of the tests that were conducted last week were returned under 24 hours, which is great news for our contact tracing efforts, because the more timely we can get our tests back, the better impact we can have in tracking down and containing future spread. We have also incorporated Texas, Arizona, California, as those have been identified as 3 states that have a lot of tourist impact to Hawaii. And therefore, Texas is trending up. Arizona and California are trending down. So that's good as we once again reopen our travel to Trans-Pacific in the upcoming weeks. So we're going to be paying a lot of attention to the trends from our sister states that we get a lot of tourists from, and also remembering that we have a lot of residents who do conduct business and return travel as well. And I believe Hawaiian Airlines just announced today they're going to start to reopen their direct connection flights from here to Las Vegas. So keeping an eye next week, we'll add at least Clark County from Nevada to this as well. So that ends the data highlight portion of the meeting. So I'll leave this up for a little bit, but this should have been sent out. And once again, we're still working out the flow of information dissemination. But in terms of 2 articles that caught my eye this week, and I highly encourage everybody to submit articles that you may not have had time to read, but are interested in. So there was a study. Let me see if there's any chats. Sorry, I'll get to the comments after I stop sharing the screen. So there was a study published in the Lancet, I believe 2 days ago, where they tried to do a large cohort type cross-sectional antibody test to look amongst populations of diabetics. And so I'll go over the strengths and limitations of that study. And then a really good starting point for us as we start to think about looking at mental health and long-term impacts for the state. The Health Affairs article looked at COVID impacts on hospital admissions for the past few months. So not going to do a super deep dive, but just wanted to bring this to everybody's attention if you wanted to look at this. So this particular study, strengths, it provides a template for a broader surveillance strategy by reducing selection bias by using a national sample. However, the limitation of this, because they took it from subjects who go to dialysis, it's like very limited in its generalizability and less likely to be mobile, which we know impacts their probability of getting COVID, and you have survival bias as well. But this is at least one of the few studies I've seen that's large enough to start to look at seroprevalence of antibodies for COVID. And then I think this is of huge importance for Hawaii specifically because of our demographic, and also we know we have a lot of adverse health outcomes that are coming our way. So this is a good start looking at a national perspective. Limited generalizability for Hawaii, but I think this is going to provide a strong template for a lot of us who look at hospitalization data and definitely focus a little more on mental health and long-term health impacts we can find a lot of similarities from this national study. So let me pause there before I hand it over to Marguerite and Andrew and Lee and Tom to talk more about the vaccines. But any major comments? And I apologize, I only have two eyes and a very small brain, so I wasn't able to multitask and look at the chat. But
Thomas, can I ask
yes,
a question?
of course.
That 10% one. This is right. We talked a lot about that in my finance team.
Okay.
That same study from the Lancet, everyone just ripped it to shreds because one, the diabetic people are just so self-caring. We actually thought it was pretty high, the 10% seroprevalence. People on my team were like, wow, that's actually higher than we expected if the people who are in that community should be taking more care. So I just threw this one in from New York, which is an amazing, they did a super focused study of the Orthodox community, and they did 1/3 of the Orthodox community in Brooklyn, and they had a 44% even, and this is right, this was like last week or 2 weeks ago that the study was done, and months after the peak, which is interesting too, because a lot of people are worried that the seroprevalence dies out after 3-4 months. It's even, you know what I mean? There's some of the studies were worried about that. So I just countered it. Who knows what the reality is? I actually think the diabetic one shows that it's higher than we think. And then there was another study I'm trying to find out of Tokyo, that a Tokyo study of about 1,000 people. The problem with that study was that it was just a company. They hit like 47% in the Tokyo. And Tokyo is such a wild place because Japan's basically done nothing during their very low testing, but healthy old people. So totally different factors to compare, but interesting. I like that Lancet study. I feel more optimistic about it, actually. To me, it seems like, I don't know if anyone else believes the same, but.
No, thanks for that. And I'll definitely take a look at and encourage others to take a look at the other study. I think what this highlights is something that I've talked with a few of my colleagues, Levi especially, where there's just there's so much information coming at us, and a lot of times it takes you actually have to read it through to find out limitations. But all people are, if you're writing a news story, you're just going to find, you're just going to focus on like the eye-grabbing statistic or conclusion without understanding that it's not generalizable because of the population that was conducted and the limitations, et cetera. So, but I brought it up as an example for that in particular, because I know that's something we're trying to look at in Hawaii in terms of, are we ever going to be able to establish or find a study, but also the fact that there's just so much information coming out daily that's hard to keep up with. But then if it makes it to CNN and then 20% or 40% of the people here pick it up, they're not going to be able to understand the nuances, and then all they're going to take away is the wrong conclusion. So I just that was one of the big reasons why I shared it with the group. But I'd love any other comments for this article or the other one.
Quick question, Thomas, just on the data, do you know what the confirmed PCR false positive rate is? Isn't it like 1 to 1.5%? As high as 4%, but I'm just, I'm curious if we're hitting false positive, 1% is kind of assumed false positive. I've seen some studies say 1.5 to as high as 4, depending on the counts. So I'm just wondering if we're ever going to get, if we're at 2.4% testing positive right now, if we hit 1%, are we hitting the false positive rate? I'm just curious if that's being counted, or how the Department of Health even handles that, the false positives.
That I'm not quite sure, but we have Janet here. I don't know if you have the insight or, but this is not my forte. I apologize.
Well, there are different kinds of PCR testing. So the standard, and maybe Francis can weigh into the standard RT-PCR. I don't know that we know the false positive because that's sort of being used as a gold standard. But the point of care PCR tests have a sensitivity and specificity both hovering around 90%, which would mean around as high as a potentially 10% false positive or false negative, but I'm a little out of my purview here.
I will say that you know, so that sounds about right, Janet, in terms of the sensitivity. But that's assuming every single test is conducted appropriately, getting the right amount of sample, is not contaminated. But but from what we've seen, that's not, always the case, and that could drop the sensitivity.
And
but we just don't know what it all. Yeah.
The sensitivity is about the simplistic way I think about it. Sensitivity is about false negatives. Specificity is about false negatives.
Exactly, correct. It's false. And Robert, you bring up a good point, and I'm working on a blog post on this too, where, as we transition into antigen testing and eventually antibody testing, a false positive and a false negative have two completely different connotations and impacts for an antibody versus an antigen / PCR. So I think communicating that difference to the public is going to be important as well.
Yeah, I think it's very interesting. I just shared the link to the Tokyo study. I think it's a preprint, but supposedly it's pretty reliable. But it's interesting to see Japan, because we ever have the bubble with Japan. I don't know if Japan's ever going to let us in, but yeah, that, somewhere else to consider, considering they're like a quarter of the economic impact.
No, thanks for that. I'll find 5-10 minutes in the next day to look at it. But any other thoughts on the two articles?
Janet, maybe I can ask one question to Thomas. How do we get this done? Why don't we just do a study? How much is it going to cost? 100,000? Like, let's just fundraise to do the seroprevalence study. I mean, it's so important to know what the penetration is in the state. I mean, what does the DOH need?
We need a plan to do it, and I think that's part of the strategic testing plan work that is in process. And like almost everything we're doing, it's not not on the timeline that we'd like it to be, but it's certainly moving much faster over the last month than things have moved prior to that. I don't know that a single point in time, very high accurate seroprevalence study is actually what we need. I think what we need is an ongoing approach to testing and surveillance that provides us with timely and actionable information about where and how the disease is spreading in the state. So I think that's where I would put our resources, and I think we have the resources to do it. It's just making things move, especially now that the CARES funding is supposed to be coming available for us to actually use within DOH. We keep hearing it's right there, but we're still on the cusp. I mean, we do need to hire additional epidemiologists and primarily epidemiologists. And I know that many in this group have also contributed enormously to our ability to analyze the data and all of that. And there's study design and just moving ahead and getting it done with a lot of competing priorities.
Robert, I will say, and I'll direct you to the Lieutenant Governor's press conference today. He did mention, it's a start. At least they're going to start. And Janet, please correct me if I misheard, but with the new Trans-Pacific travel, he did mention they're going to try to enlist or ask for volunteers to get a secondary test.
So he has floated that as an idea.
So it's nothing concrete.
It's not a plan. There's nothing concrete there.
Okay, that's helpful.
That wouldn't provide us with a population prevalence study.
No.
Because, so I mean, you guys understand the methodology issues there. So
yeah, I know he floated that back in July before I left. So, but I guess it's still just a thought and nothing concrete.
I think that Maui County actually has a much more well-developed small proposal to do kind of an evaluation test to look at, what are the cases that come through, how many of those who had a negative pre-test wind up testing positive while they're here, including plans for multiple tests and for incentivizing people to participate in that. So I think the Maui plan, though smaller, is actually further along in terms of operationalizing it. Perfect.
Sounds good. Those were great questions, Robert, and really good insights from Janet. Anything else before we move on and I hand it over to Andrew to speak about vaccines, because that's going to continue to be a hot topic in the next however many months, especially for Hawaii, and as the election comes very close. So if no other questions, Andrew, I know you didn't really prepare any slides, or did you want me to bring any slides, or I feel like you guys should just speak and use your expertise?
Yeah, I can go ahead and just speak. Margaret just put together some brief slides too, so we can have some visuals and not just look at each other's faces at the moment. So let me go ahead and pull it up really quick. So again, my name is Andrew Abe. I'm a pharmacist by training and one of the faculty members at the Pacific Health Analyst Collaborative. Just giving a brief snapshot of kind of where we are with the types of vaccines out there. I know there's a lot of things going on. So this isn't, this is just a brief update as well too, and we'll be glad to have a deeper dive in the future as well. So a lot of you have seen a lot of clinical studies going on, and I gotta say, this is probably the fastest I've seen the FDA hustle in regard to clinical trial development. And this is true, it usually does take a very long time to get any drug to market, but what we see now are overlapping trials. We see combination phase 1, phase 2, phase 3 studies, and they're all kind of grouped together. And that's why you hear headlines like that one, the AstraZeneca study that got stopped because they found incidents of potential transverse myelitis in one patient. It's because the trials are overlapping. So we are quicker to a vaccine, but at the same time, it comes with some potential drawbacks as well too. So we are definitely moving at speeds that we've never seen before. That being said, the trials, all of the phase 2 trials right now are designated to end sometime around 2022. That's full completion. However, these drug trials have been granted fast track designation by the FDA, meaning that approval may happen prior to completion of these studies if sufficient data is found and the power is met to show significant benefit with these vaccines. These are some snippets from a recently published article. It kind of just gives a brief snapshot exactly how many things are currently in development. However, in regard to what the FDA is taking a look at, there are 4 companies right now who are, I would think, the quote unquote front runners or 5 companies in regard to development of a vaccine. And those are the ones bolded here: Pfizer, Moderna, Johnson & Johnson, AstraZeneca, and Novavax. And what I like about this illustration, kind of briefly chunks up kind of like the platforms. Traditionally, when we heard of vaccines, we have the traditional inactivated, or the viruses, the actual virus that causes infection, just inactivated. We also have attenuated, which means just a weakened form of the actual virus is injected. But we also have more novel forms in the modern category. Novavax is the only one in the Warp Speed, Operation Warp Speed, that is not currently in phase 3 studies. It's currently in phase 1, phase 2. This is a little different. It's not an mRNA vaccine. It's actually an antigen vaccine where it's presented in its unique adjuvant, a matrix, that kind of presents the antigen to the body's immune system to elicit that immune response. AstraZeneca and Johnson & Johnson, these vaccines are also not what you would consider mRNA vaccines like we've been talking about. These vaccines are actually embedded into adenoviruses, cold viruses. And these vectors are then coded with the viral spike protein. So one thing I forgot to note, I should have gone back a little further. One of the main target for these vaccines to elicit an immune response is the spike protein that is prevalent on the coronavirus, the SARS-CoV-2 virus. That's the main target for immunogenicity for these vaccines. So AstraZeneca and Merck's vaccine codes the spike protein into their viral vector. What we see in the classic and the more modern vaccines, I believe there's a point of contention that I'll bring up again. These vaccines have been seen to be more stable at refrigerated temperatures, which may help with distribution down the line. The very new vaccine from Moderna and Pfizer, these are also in phase 3 trials right now, and these are the mRNA vaccines. These vaccines are nanoparticles that are encapsulated, and this mRNA is actually taken up into our host cells, and we produce the spike protein, which then produces that immune response. So we become the producers of that spike protein, and our body produces that immune response as well too. And again, this is currently in phase 3 development as well. The problem that we've heard of in these studies are stability. They've historically had to be stored at very cold temperatures. Right now, there are some preliminary storage stability temperatures, which suggest that they could be stored about a week within refrigeration. So this is still an ongoing thing that we have to go ahead and address in the future. Other things that, when you take a look at the phase 3 studies that also have to be, I guess, demonstrated or investigated going forward, is its safety and efficacy in a broader population. Right now, these studies look at 2 big populations: young adults, 18 plus, and older adults, usually 55 and over in regard to population. Right now, the lowest age range goes down to 16 years old. Also, too, is that very few studies are expanding out to more immunocompromised patients, patients with HIV, Hep C, all those kind of other populations. And that population also needs to be better understood as well, too, because of the lack of immune response seen in this population. We don't know the outcomes yet. So these are things that we probably need to hear about more in ongoing phase 3 studies in order to apply to the population. However, seeing how they progress now, I don't believe we will have information for vulnerable populations and pediatric population by the time this vaccine is released. It's going to be more of a state level decision on how that will outroll and what type of patient population will be needed for that. That being said, that's kind of like a really high level run through of where everything's at. Like I said, drugs for Johnson & Johnson, AstraZeneca, Moderna, and Pfizer are all in phase 3 studies right now. They're currently in development. Pfizer, as of this past Monday, has enrolled 35,000 patients into their study. One other big thing I do want to note is that all of these drugs, except for Johnson & Johnson, come in a 2-dose vaccine, meaning that you take it day 1 and then you follow up about 3 to 4 weeks later for second administration. And that may prove difficulty too when we come down to our patient population. Okay, so that's kind of like what I wanted to share in a nutshell. Marguerite, Lee, if you'd like to say anything as well too and follow up with some of the points.
Yeah, thanks, Andrew. That was really great. So anyway, I'm a biologist. I'm not really a health professional. But what's interesting is this RNA is just super brand new. So new meaning that it's never been used as a vaccine before. So this is like a first time technology. So anyway, it's just kind of interesting. I found it interesting that the ones that are bolded were the ones that were supported by Operation Warp Speed. And that's why there's much more further along. There are vaccines that are more the traditional classic types. And so the thing about those is that they're reliable and very well tested, but they do take a long time to develop. But it's just something to be a little bit concerned about, that our government did not choose to include one of those as in the warp speed. But that being said, it's nice that there are lots of choices so that hopefully it will be actually available once it's ready for broader distribution.
To follow up with Marguerite, the other studies are being conducted in other countries as well too. For the FDA, they historically have never approved a drug based off of other countries' studies and have inclusion of populations representative of the United States. Like, you need to have different ethnic diversity in your trials to be approved usually. And so if these studies are not conducted within FDA's, what they would normally presume appropriate, they may not be approved here, even though they've gone through trials in other countries. However, this vaccine has taken us to places I've never seen before. So maybe there's a first time for everything, and that could happen. Additionally, too, of concern is that when you take a look at some of the primary outcomes in these studies, there wasn't a draft guidance illustrating how these drug companies should target or evaluate the efficacy of these vaccines. So what we have are some who are evaluating COVID disease based off of symptoms, some based off of tests. So in regard to looking at apples and oranges in an indirect efficacy comparison, it's going to be very difficult to determine which vaccine is better than another vaccine. So we may end up with very confused messages if more than one is approved in regard to which population gets which drug, if it's better in a younger, better than older population. And that's something that the state will have to make a decision on how to move forward. I would not anticipate the federal government taking a preference unless there's strong evidence either way.
Robert, does that answer your question? I know you threw up the Sputnik vaccine in the Lancet article, but I think Andrew did a good job explaining why at least they weren't included by the FDA.
Oh yeah, no, I thought he was doing a global. I mean, those are both the recumbent spike classic style. I'm very skeptical of the Russian one, especially lacking the phase 3, but it's only interesting because I think 20, 30 countries have already ordered it. So it just becomes a vaccine nationalism, and we'll see what this happens. And now it's going to be a state kind of issue. We'll see. I'm just curious if what percentage of people here are ready to take the vaccine if it was approved tomorrow? I would love to just know if you had a safe. I'm just curious because I hear very mixed messaging on the vaccine kind of readiness of people. Or it could be private information, I guess. I'm just curious.
So I'll be the first in terms of I probably won't have a choice as a military member. If I'm assuming the military is going to be one of the first to get it. So and that's a big thing. We're trying to figure out who's going to get it first, I think, or who's going to even have access to it, whether or not you want it, or even if you want it, we may not even get it. And I think from a modeling perspective, working with Monique and her team, we were discussing some of the assumptions yesterday. I think that's a very big factor. You could have 50%. I think I've seen polls nationally or even state, some local polls saying up to 50% might want it. But it's the next question that people may not have thought about is, can they even get it if they want it locally or even nationally? So I'll say that I'll get it probably just because I have to.
I want to believe in the science and our FDA approval system. That's what I want to say. But I've also seen I Am Legend. All joking aside, I would believe in the science, and I would go with it if the science was there. I hope there are no politics involved in the approval of this, and they go based off of best practice.
Yeah, I would say that, I just want to say that even though it is like very, very fast, the reason why is because they're actually relying on a huge amount of research previously. So, there have been previous SARS viruses developed toward the spike protein. So, and then some of the adjuvants have undergone thorough research as well. And so they're using parts that have been approved already. So they're sort of slotting it in the novel parts for this current novel virus. So that's part of why they can accelerate it. And also just the huge financial investment because of the desire to have it good to go. So a lot of the 15-year timeline is because traditionally they don't want to invest a huge amount of money until each step has been demonstrated, and then moving on to the next step. But this is different with the urgency. We're just throwing everything at it and then whatever comes out. But Andrew is absolutely right, though, that I have been reading the literature, and the assessments of the viruses, like it's really hard to compare the results from study to study and vaccine to vaccine because they're looking at it in different ways. And so had they actually standardized the guidance, that would have made things a lot more clear. But I don't think it's not that just because of our chaos at the government that it's going to be, doesn't mean that it's necessarily going to be dangerous, but it looks very promising in terms of development and having something come out soon.
Any other thoughts on the vaccine itself? Thank you, Marguerite and Andrew and Lee, everybody who put time into that. I think it's important before we even start to shift to the logistics of it, which is a whole nother can of worms, which, you know, I'll put some slides together and talk about next week. It's important just to understand what the leading vaccines are. And I really appreciate the team. You know, you guys did a really good job just outlining the three major types of vaccines, the ones that are leaders, you know, going out, and then we'll see, you know, who wins on the back nine. If you're a golfer, we're in the home stretch now. But any other questions for our experts here or comments? And if it bleeds into logistics, that's fine. It'll be a good tie until next week. That's Tom. You have a great point. If you were 20, would your answer be the same? I mean, you're 40, so I mean, it's 20 years it's not a big difference, Tom. So I think you're okay. But yeah, I think age plays a role in risk tolerance. I know, you know, that's different for everybody. So we'll see. We'll definitely see. I know from Andrew mentioned last week from a data perspective, tracking the data, you know, tracking who's getting it, right? You know, that's something you're interested in seeing and figuring out. Too bad Janet had to step up, but I'm wondering, and if anybody has insight to what systems are currently set up in place to track vaccines. I know DOH has like an immunization registry, but I'm not sure if that's going to be, they're going to utilize that for COVID as well.
I think Janet can confirm the Department of Health is restarting the immunization registry. And I think the push is because of the COVID, because I think the HHS is requiring all vaccination to be reported to a registry. And the pharmacies and the providers are really pushing. So I think the Department of Health is getting ready to restart the immunization registry, electronic receiving data. I mean, they have kind of suspended it for a few years because of funding issue, but I think now they get the funding, so they are starting again.
No, that's really helpful. I didn't know that the registry was dormant for a while, so it's good to know that it wasn't. It's brought back to life, so that's good.
Mm-hmm.
So
yeah, it's coming back to
some
life.
data. Okay, that's really good.
Mm-hmm.
Andrew, could you bring back sorry, I apologize, Marguerite, was it the presentation you and Andrew put together, or was it the? Do you have the next slide, Andrew?
Oh, yeah, thank you. Sorry, I just wanted to share this. I thought was a really, really interesting point. The author of this review article made the point that all of the vaccines are delivered intramuscularly. And so when you have a normal infection, it goes through the nasal cavity, of course, and then you have an IgA and an IgG response. So in the upper respiratory tract, it's mostly IgA, and in the lung, it's mostly IgG. So intramuscular delivery will generate an IgG response, and all the vaccines will do this, but only some of them can elicit an IgA response. And so they brought up the point that we might be developing vaccines that could prevent us from getting severe disease, but yet we may still be infectious. So like your lungs may be protected from having severe disease, but if you can still get infection through the upper respiratory tract, you could also transmit. So you could be basically like an asymptomatic carrier in that case. So that's something to watch in terms of vaccine development.
That's really interesting. This is a great slide. One question that I have, Marguerite, after hearing that is, I'm assuming we don't have enough data yet, but if we do, would we be able to conclude if the lungs are protected from this vaccine, would that mean that we would be protected for other organs as well? Like I know there's been, evidence of, liver damage or other organs from COVID, but lungs have gotten the majority of the attention, and rightfully so. But do you know if it's going to work the same way for vaccines and the other organs?
Oh, I don't know if maybe Andrew or Francis knows more, but I think just from the physiology, it enters, it's the route of entry, and we have a lot of ACE2 receptors in the respiratory tract, and that's why it lodges there, and that's the initial site of massive replication. So as far as I understand, then it spreads, but I could be wrong. I don't know. Do you guys know more?
Hey, this is Brian Wu. So some of the complications that's still being teased out, is secondary to kind of that inflammatory response. So some of the other end organ damage. So I think for the vaccination, if it's able to prime an immune response, even though you may potentially be able to transmit it through your, nasal pharynx, through your nose, throat, whatnot. Again, that's the point of vaccinations. It may not necessarily protect you from transmitting, because you could still have some secretions if you had a high viral load. But if you're vaccinated, it'll decrease the pathogenicity for yourself. So that's kind of the whole goal for this. And for the routes of administration, with some of the almost gene vaccinations, where they're actually inserting a virus that has this gene that goes into your cell, and then your cell will start producing this protein, the spike protein, that primes your immune system to fight it. So you're basically making just a piece of this virus, but not the whole virus. Even though it's local, you have circulation throughout, so that's kind of the hope, right? You have this big enough response, your cells will spread it, so it wouldn't be the same as kind of our historic types of vaccination. So it is fascinating, and for me, my biggest concern is, historically, for all that's happened in COVID, when the FDA has approved something under emergency use authorization, EUA, that hasn't been very vetted well. So that question of, would you take this vaccine tomorrow? Kind of depends, right? We don't know. We don't have enough data to make that judgment right now. And if the FDA does approve it, should we have faith in the FDA? Well, right now with our current political climate, if it's under an EUA, a bit more caution than if it had a typical full FDA approval. But it is fascinating. Thanks for the overview of this. And there's a lot of other great ones out there, YouTubing it, kind of going over other kind of facets of vaccination. UCSF had a pretty good one about a month ago, kind of going over how other vaccines are approved. So even if it's not studied in specific populations, the types of immune response you're seeing in your tested population, you potentially could extrapolate that to other populations. So it's incredibly fascinating. And yet, I apologize if I came late, but you've probably heard in the media as well. This is the one very unusual case where pharmacies are actually pushing back against the FDA to approve things. So incredibly fascinating times, but thanks, that's my half a cent.
Thank you, Brian. It's always helpful to have a medical doctor provide, because you guys have different insights that are so valuable, because you're seeing patients, and your perspective is unique and different. So definitely thank you for that. I did not know about that pharmacy situation that pharmacists are pushing back, which I'll defer to our pharmacist here, Andrew, if you have any thoughts on that. But that's I'm speechless to hear that.
This drug is moving so fast that it's busting through what we traditionally perceive as safe process and a due process. And especially with vaccines, because it's a preventative type of intervention, you need a larger number to have adequate power to show a significant difference. And there's been a lot of times in the past where we've rushed to things and it provided more harm than benefit. So there's that historical remembering of when we've rushed things, bad things happen, and that we won't see efficacy or true safety until it gets out to the public. And by then it's already out to the public. So it's just the unknown and the untested. And I am hesitant on it as well. Yeah, I think the phase 3 data is going to be very limited. They're going to show a very minor significant benefit, but I think that'll have to do. And administration is tricky because you do have to come back within, like I said, a couple weeks. And between trials too, I think each of them have a slightly different schedule and different storage and different everything. So it's going to be a logistical nightmare if all 4 of them get approved at the same time and in different age population. So it'll be difficult. It'll be very difficult if it comes out all at the same time, and it'll be a mess at the pharmacy of how this will happen. Yeah. So hopefully we'll be there to
so definitely
make sure
go back to the same clinic for sure. But
the problem too is that I think they're reported to the registry, but pharmacy records aren't shared across systems, right? It's like Epic and Cerner, they don't talk to each other, the EMRs. Pharmacy records stay siloed. So unless we have an all-payer claim database, we're not going to truly know if someone goes to a different pharmacy unless they tell someone. And their memory has to be good. And my memory is not good. So I don't know if other people's memories pharmacies will need to have some kind of reminder system to tell people to go back, because if it comes out this fast, we won't have data on variants from how long it is since you missed it. Like if you're 2 months off, do you have to start the cycle again, or can you just take the second one? I don't think we'll have that by the time it comes out, and people will just be giving injections left and right. Some people might get 4 injections, and we don't know what's going to happen to them, or they might get double. If they go to Walgreens and CVS and they get 2 different ones, I don't know what's going to happen to them. So there's a lot of unknowns, and I think we just need more guidance and framework set up before it happens.
So Andrew, what you're saying is we need, besides the APCD, we need people to assist with creating a system that tracks everything and informs and feeds back to our Department of Health, so they can feed back to FDA and the CDC and NIH for further guidance.
Yeah, if there could be like a soft stop at the pharmacy to tell people like, hey, this person already got a vaccine a week ago, and it reminds them to come back in 2 weeks, and this is the only one they should be receiving and not a different one. Let's say like they ran out of it for some reason on their second dose. What's going to happen if they run out on their second dose? Are they going to wait? Can they wait? Do we have enough stockpile enough? So if we have 10,000 on day 1, will we have 10,000 3 weeks later, 4 weeks later, or will we run out? It's going to be a hard logistical nightmare to match stockpile with first and second doses and make sure that people get their first and second doses.
Andrew, are you familiar with the 76 swine flu vaccine? Wasn't that the one that got canceled? Remember in the 70s? I mean, I just looked it up in Wikipedia. That's the one that they did 25%, and then they reversed the cancellation because it was so dangerous, the vaccine, after it was approved. I'm not anti-vax at all, but I remember that was a major scandal. In the 70s, that was Ford. I just put the Wikipedia link, but it had some, I forget the name of the syndrome, but like 25% of the US got the vaccine and then they canceled the program. So I don't know who said that was concerning about the FDA, but something interesting. Yeah. I'm not aging you, Andrew, by the way. I was saying that, just a warning. Yeah.
No, there have definitely been, you know, big lessons learned, I guess we should say. But I think, I don't know. I mean, I guess at least in the science community, there's optimism that there's so many eyes on this and so many trials that we will learn as we go, and hopefully that knowledge will be used to continually refine, you know, the virus, the vaccine itself, as well as the delivery. But that all relies upon, like as Andrew was saying, information systems. And so if we have no information system, then it will be total chaos. So yeah, so we really do need to work on holding our government accountable and having tracking and learning so that we are continuing to improve this for the world and for the population at large, because there's all kinds of complexities. There's just so much we still don't know. But so maybe, and then Andrew, in this case, maybe there is one upside to this lack of preparation for delivery all at once upon readiness, because it's just not possible logistically to get the vaccine out to everybody. So maybe in this case, if the info systems are not up there to snuff, then maybe that's a good thing. I don't know.
Yeah, usually over time, companies have figured out what happens if you deliver it at inappropriate times as well too. Hopefully we work out a system where we keep track of who has been vaccinated and with what, and make sure that we have stockpiled those doses for their second round if needed. I think the right minds are on it. I think we just need to figure out who's working on it and how we can best support.
I learned so much more in this 30 minutes than I did in my one semester of immunology. So thank you. Thank you to the experts here. Tom, hopefully Janet can join us next week. We'll definitely be revisiting the vaccine issue, but more from a logistical, both from a data and actual vaccine distribution point of view, because that is also a often forgotten part of the vaccine discussion. I know definitely not within this circle, but I think a lot of the general public hasn't even thought about the heavy lifting. And Andrew alluded to that in terms of the storage and the temperatures that are required for some of the leading vaccines. And one of the articles that I read, they have to make specific storage compartments for some of the mRNA vaccines, and they're only meant to be open twice a day for a minute at a time. So if that's the case, you can only pull whatever vaccines you need, but then you have to have the appointment set up so you're not wasting those vaccines. So there's a lot. I have to do a lot more reading and research, but we'll definitely be talking more about the logistics of vaccines and tracking the data and where we are and where we need to go for that. But definitely, this was a great baseline understanding of what the major types of vaccines are. And Tom, you're totally right. That was a large reason why they shifted, was because there's a glass shortage. I mean, who would have thought there's a glass shortage? And I heard from one of my colleagues that there might be an aluminum shortage as well. So Coca-Cola is going to have a monopoly on all the cans, and we're going to have to find other ways to get our other types of beverages. So, other unintended consequences of COVID that are impacting the health and how health is delivered. But we're still focusing on modeling, and hopefully we can provide some updates, at least for the vaccine discussion, with Monique. Maybe next 2 weeks, we're going to look at that as well, from a modeling perspective. So it's 5 minutes till, and if there's nothing else, I want to give back 5 minutes of our time to you, because I know we went over a few other meetings. But if there's no other comments, if I could poll, if you feel comfortable sharing feedback, was this an improvement or like a sustain in terms of the new format in the direction and how we set it up? Yes, no, thumbs up. If we had a thumbs down, I would ask you thumbs down, but thumbs up. Perfect. Well, thank you everybody for participating. I highly encourage you to check back on our HiPAM website. We've, thanks to Adrian and Joyce, we definitely revamped it a little bit to further provide the public with some of the information that we've discussed here. So please check it out. And if you want to share, please share that link with everybody, because now we're able to offer not just the modeling, which is still a very big part of it, but now furthering the discussion for all the other aspects tied into data and science for COVID. So with that, thanks everybody for coming, and we'll see you guys next week, Thursday.